everyone. Today we will continue our lecture about the fundamentals of the intra-aortic balloon. The first section in this lecture today about the hemodynamic effect of the intra-aortic balloon. And the hemodynamic effect of the intra-aortic balloon includes the changes in the systolic events and diastolic event, changes in the coronary blood flow and cerebral blood flow, and also changes in the pressure volume loops. So regarding the changes in the systolic event, during the systoles, as you see the intra-aortic balloon, it will start the deflation. And this rapid deflation, it will create a vacuum effect, which like a negative pressure inside the aorta. And this will lead to reduction of the systolic pressure. And the systolic pressure reduction will lead to reduction of the afterload. Reduction of the afterload and peak systolic pressure will lead to improvement of the stroke volume that will be ejected by the left ventricle into the aorta. And also reduction of the afterload and systolic pressure, both of them at the same time, will lead to decrease of the workload that should be done by the heart to overcome the afterload. And consequently, this will lead to reduction of the left ventricle oxygen demand. So all these are the changes related to the systolic event. Going to the changes in the diastolic event, and as you see during the diastole, the intra-aortic balloon will start the inflation, and it will occlude almost 90 to 80% of the aorta, and this will lead to upward displacement of the blood toward the upper limb and the cerebral circulation, and also toward the coronary circulation, and downward to the distal organs. And during the balloon inflation, during the diastole, this will lead to increase the main arterial blood pressure, and also will lead to increase the augmented pressure. And both of them will lead to the increase the perfusion to the organs like the brain, the heart, and the distal organs. And after the intra-aortic balloon pump inflation, this will lead to deflation of the intra-aortic balloon, which will lead to the reduction of the left ventricle into diastolic pressure. Regarding the changes in the coronary blood flow, diastolic augmentation of the intra-aortic balloon will lead to increase the diastolic pressure time index, which is a surrogate of the coronary blood flow. So it will increase the coronary blood flow to the heart, and with this will lead to increase the oxygen supply to the heart. And to understand the changes in the coronary blood flow, as we mentioned before, you have to understand the concept of the diastolic pressure time index and the tension time index, or the systolic pressure time index. And as you see here, this is the unassisted waveform prior the run of the intra-aortic balloon, and this is the assisted waveform. And this part, the area under curve of the diastole, is equal to the diastolic pressure time index, which is a surrogate of the coronary blood flow. This area under curve, it will be, this area under curve, it will be increased with the diastolic augmentation. As you see, this area under curve compared to this one, it's much higher. So the coronary blood flow will be increased because the intra-aortic balloon will start the inflation during the diastolic filling period, which is a time for the coronary perfusion. And this graph also showing the same effect. During the intra-aortic balloon inflation, the diastolic pressure time index is increased. So it will increase the coronary blood flow. And the next part is about the changes of the left pressure volume loops during the run out of the intra-aortic balloon. So the first graph, which is the baseline graph, which is the dashed, the black dashed graph. And as you see here, this is the working point of the heart during the systole, which is a surrogate of the afterload. And this is the peak systolic pressure, which is elevated prior to the use of the intra-aortic balloon. And the point from A to B is equal to the isovolumetric contraction phase. And the point here is equal to the end diastolic volume, and the point here is equal to the end systolic volume. And the difference between the end diastolic volume and end systolic volume is equal to the stroke volume. And as you see, after the run of the intra-aortic balloon, the first thing is that you notice that the isovolumetric contraction phase is becoming shorter, and the duration for the contraction of the isovolumetric contraction phase is becoming shorter. So the workload that should be done by the heart will be less. So this will decrease the oxygen demand. And also, as you notice here, the peak systolic pressure after the run of the intra-aortic balloon has been decreased, and also the afterload has been decreased from this point to this point. So this is the resistance against the heart. So the heart will start the ejection of the blood because of the reduction of the afterload. And as you notice that after the run out of the intra-aortic balloon, the difference between the end diastolic volume and end systolic volume has been increased, which means that the stroke volume has been increased compared to the baseline. And as as you see that the changes in the pressure volume loops is demonstrated as you see here, reduction of the peak systolic pressure and reduction of the afterload, and both of them will lead to reduction of the workload by the heart, and this will lead to reduction of the oxygen demand. And also, as we said, that the isovolumetric phase has been shortened from this point to this point, so the time for the isovolumetric contraction has been reduced, and this also will lead to reduction of the oxygen demand by the heart. And as you see, the third point is that the stroke volume has been increased because the reduction of the afterload, so the heart will be able to eject more blood, and this will lead to increase the stroke volume and consequently increase in the cardiac output. Going to the next part, which is the changes in the cerebral blood flow. As we see during the diastolic augmentation, more blood will be displaced to the upward to the upper limb and cerebral circulation, and this will lead to increase the the cerebral blood flow. And it has been published in many publications that the intra-aortic balloon, especially on this patient with heart failure, is able to improve the cerebral blood flow and cerebral circulation. And as you see, if you check the transcranial Doppler waveform, so this is the baseline here. And as you see, this is the waveform of the cerebral circulation. And this part is equal to the systolic part, and this part is the diacritic notch, and the remaining is the diastolic part. And after the run of the intra-aortic balloon, you see this is the baseline systole, and this is the diastolic augmentation of the diastolic cerebral blood flow. So it is confirmed that the intra-aortic balloon is able to increase the cerebral blood flow due to the increase of the diastolic augmentation of the cerebral blood flow. And the next part is about the improving of the intra-aortic balloon performance. So if you have intra-aortic balloon, how you will be able to improve the performance of the intra-aortic balloon? There are many factors that will control that affect the performance of the intra-aortic balloon. So there are factors related to the balloon itself, and there are factors related to the patient. The factor related to the balloon, like the balloon volume, the balloon diameter, the position of the intra-aortic balloon, and the intra-aortic balloon configuration, like the augmentation percentage and the timing of the intra-aortic balloon. And the other factor related to the patient, like the heart rate, the stroke volume of the patient, and the systemic vascular resistance of the patient. So the first factor, which is the balloon volume. So if the balloon volume is equal to the stroke volume of the patient, let's say if the balloon volume is around 40 and the 40 ml and the stroke volume of the patient is around 40 ml. So if both are equal to each other, so this will maximize the augmentation of the intra-aortic balloon during the diastole. If the stroke volume of the patient is lower than the diastolic, let's say if it's less than 25 ml, so this patient unlikely to benefit from the intra-aortic balloon and the diastolic augmentation will be blunted. And the next factor is the balloon diameter and the occlusivity. So ideally, the intra-aortic balloon should occlude 90 to 80% of the intra-aortic balloon diameter. And the greatest augmentation occur with complete occlusion of the aorta. So if the, as you see here, so if this is the maximum performance by the intra-aortic balloon due to maximum occlusion of the aorta by the intra-aortic balloon, but this one is decreased performance because the balloon occlusivity is less than 80%. So the blood flow will be directed to the organ. It will be suboptimal. And as you see here, with maximum occlusivity, the blood flow going to the organ will be maximized here and here. This one will go to the heart also and will go to the coronary perfusion and to the cerebral circulation. And the next factor is the balloon position. If the tip of the intra-aortic balloon is more proximal to the or more proximal or closer to the aortic valve, this will maximize the diastolic augmentation. And if the balloon migrated downward more, so this will lead to suboptimal performance of the intra-aortic balloon. And factors like balloon configuration, which is related to the augmentation. So the augmentation percentage might affect the IABP performance, like if you are setting the augmentation percentage like 70%, so the intra-aortic balloon, the diastolic augmentation will be less. And as you know, the timing of the intra-aortic balloon will affect the intra-aortic balloon performance, and we will explore this in the troubleshooting for the intra-aortic balloon. And the next factor, which is the factors related to the patient, like the stroke volume. And as we said before, if the stroke volume is not matching with the balloon volume, so the patient will be unlikely to benefit from the intra-aortic balloon. And if the stroke volume is than 25 ml with each cardiac cycle, so there will be a little diastolic augmentation happen during the balloon run out. The heart rate, if the lower the heart rate, the higher the performance of the intra-aortic balloon, because when you decrease the heart rate, you will increase the time for the diastole, which is the time for the balloon inflation. So the patient will achieve maximum will achieve maximum benefit from the intra-aortic balloon. But if you increase the heart rate, so the time for the diastolic augmentation will be decreased, and the patient will not benefit that much from the intra-aortic balloon. So ideally, the intra-aortic balloon, the heart rate should be around 90 to 120. More than 120, the patient will not benefit that much from the intra-aortic balloon, and especially if he's having like arrhythmia, like LAPDF. The next factor related to the patient, which is the systemic vascular resistance. And those patients will achieve the maximum benefit from the intra-aortic balloon. Those patients with having very high systemic vascular resistance and vasoconstriction. But if the patient is having vasoplegia and the systemic vascular resistance is very low, so unlikely those patients will benefit from the intra-aortic balloon, because the aorta will be redundant and it will be dilated, and the balloon occlusivity for the aorta, it will be much less, and the hemodynamics, it will be compromised. Going to the indication of the intra-aortic balloon, There are many indications, which is mainly related to the cardiogenic shock, acute myocardial infarction, high-risk PCI, and there are mechanical factors like acute mitral regurg and acute VSD related to myocardial infarction, and mechanical circulatory support for those patients with to wean from the cardiopulmonary bypass. And also we can use the intra-aortic balloon for those patients with cardiogenic shock as a left ventricle venting strategy along with the VECMO. The absolute contraindication of the intra-aortic balloon includes the moderate to severe aortic regurg, aortic dissection, aortic stenting, and those patients with hypertrophic obstructive cardiomyopathy. The relative contraindication is the peripheral vascular disease, abdominal aortic aneurysm, and severe tachyarrhythmia. The evidence behind the intra-aortic balloon, the clinical trials, you will have many trials which assess the efficacy of the intra-aortic balloon in order to decrease the mortality for those patients with cardiogenic shock complicating the acute myocardial infarction. And from all these trials, only 3 trials are able to, this one, and this one, were able to show mortality benefit, and the remaining trials were negative. And the most famous trial, which is the IABP Shock 2 trial, which have been published in the New England Journal of Medicine in 2012, and it was a negative trial, and there was no 30-day mortality benefit from the intra-aortic balloon. But despite all these negative trials, still the high volume ECMO center and the tertiary center, still they are using the intra-aortic balloon with good outcome. The next section is about the device configuration, and as you see, the device is divided into 2 parts, the console part and the catheter part. And the console part, as you see, you will find the display monitor and the touch screen, and there is the console part for the helium cylinder, and there is also a pump to inflate and to deflate the balloon. And this is the display monitor, which show many parameters like the heart rate, the arterial blood pressure waveform, and the augmentation, and the balloon pressure waveform. And also it can show you the percentage of the helium. And this is the touch screen monitor with a lot of key functions which can control and adjust the setting of the intra-aortic balloon by the operator. And the second part of the device, which is the intra-aortic balloon catheter. The catheter is connected to the device with 2 to 3 connection. The first one is the arterial pressure transducer, and the second one is the port for the helium. And other catheters, they have a third port for the fiber optic catheter. And we have 2 types of the catheter: the conventional intra-aortic balloon catheter, which is having the 2 ports only, one for the conventional arterial and transducer, and the other one for the helium. And the second type of the catheter is the fiber optic catheter. There is extra port for the fiber optic catheter. And this is the IABP size chart and the selection of the intra-aortic balloon size based on the patient height. And as you see, there is size which is 25 for the children, and 34 to 50 which is for the adult based on their height in centimeters. And the balloon is designed to sit in the proximal part of the descending aorta, distal to the origin of the left subclavian artery and above the origin of the renal arteries. And the balloon will be inflated with helium gas, and the inflation of the balloon will lead to occlusion of 80 to 90% of the aortic diameter. And the insertion site of the intra-aortic balloon, we have 2 methods for the intra-aortic balloon insertion. The standard method, which is the through the femoral artery, going to the descending aorta. And the other method, which if we are using if the patient is having difficult femoral access, like the axillary access by the axillary graft, and where the balloon also will sit in the descending part of the aorta, but the tip of the intra-aortic balloon will be above the level of the renal artery, while the femoral approach, the tip of the intra-aortic balloon will be 2 to 3 centimeters distal to the origin of the left subclavian artery. And this is another demonstration for the different insertion technique. And as you see here, the femoral approach, the tip should be 2 to 3 centimeters distal to the origin of the left subclavian artery, and the axillary approach, the tip should be above the level of the renal artery, and ideally this one should be inserted under fluoroscopy to adjust the position of the tip above the level of the renal artery. The standard method for insertion of the intra-aortic balloon, it should be ideally through the fluoroscopy, but in our center and in many centers, they can use the bedside ultrasound, bedside echo, and chest X-ray in order to confirm the position of the intra-aortic balloon. The femoral approach, we can confirm the position of the tip of the intra-aortic balloon by chest X-ray. It should be 2 to 3 centimeter above the level of the carina, and the brachial or axillary approach, it should be confirmed by fluoroscopy, and the level should be, the tip should be above the level of the renal arteries. And as you see here, this is femoral intra-aortic balloon with tip positioned properly 2 centimeters above the level of the carina. And the axillary approach, the tip should be above the level of the renal arteries. And the insertion technique of the intra-aortic balloon, you can scan this code, and it will give you access to two of high quality videos to show you how to prepare and insert the intra-aortic balloon. This is a display monitor and the touch screen for the intra-aortic balloon, different devices and different companies. And going to the next part, which is the IABP operational modes. There are many operational modes for the intra-aortic balloon. There is the auto operational mode and the semi-auto operational mode and the manual operational mode. And in the auto mode, the machine will be able automatically to select the trigger for the operational mode, and also it will be able to automatically control the inflation timing, but the operator will have access to adjust the timing for the deflation. And also the balloon will be able to automatically manage the arrhythmia regarding the timing for the inflation and the deflation. And the semi-auto mode, the operator will activate the semi-auto mode, and he will be able to select the trigger source, and he will have the access to control the inflation time and the deflation time. And because it's semi-auto, the machine will have the automatic management for the irregular arrhythmia regarding the inflation timing. And the manual operational mode, it's used only for the pediatric cases. Going to the next section, what's the IABP trigger? What is the trigger for the intra-aortic balloon? The trigger is the signal that the machine use in order to identify the timing of the cardiac cycle, the timing for the systole, and the timing for the diastole. And based on identification of the timing, so the machine will start the inflation or deflation based on the cardiac cycle timing. So the machine can use many things in order to identify the timing for the diastole, so it will start the inflation. and also will identify the timing for the systole, so the balloon will start the deflation during the systole. So if the machine is using the ECG as a trigger, so the machine will use the peak of the R wave in order to identify the timing for the systole. So it will start the deflation of the intra-aortic balloon, and it will identify the mid or the late of the T wave in order to start the inflation of the intra-aortic balloon, because this is the timing for the diastole. And as you see here, so the balloon will use the peak of the R wave in the ECG in order to start the balloon deflation, because this is the timing for the systole. And here it will be the timing at the late of the T wave. It will be the timing for the diastole, so the balloon will start inflation here, if the machine used the ECG as a trigger. But if the machine used the arterial waveform as a trigger in order to identify the timing for the systole, so the beginning of the systolic upstroke, it will be used as um, a surrogate for the beginning of the stall. So the machine here at this point will start the deflation of the intra-aortic balloon, and the machine will use the diacritic notch in order to identify the beginning of the diastole. So it will start the balloon inflation. And if you compare the ECG waveform to the arterial waveform, you will notice that there is a delay. It's almost 120 second up to 180 second between the beginning of the ECG activity and the arterial waveform activity. And this is expected because the conduction of the electrical activity inside the atria and inside the left ventricle, and after that the mechanical changes will start in the heart. So it is expected to have this electromechanical delay between the ECG and the arterial waveform. So if the machine uses the ECG, it will select the R wave in order to start the deflation of the intra-aortic balloon. And if used the arterial waveform, so it will use the beginning of the systolic upstroke as a surrogate for the systole, so it will start the deflation of the intra-aortic balloon. And if the machine uses the ECG, it will use the end of T wave in order to start the inflation of the intra-aortic balloon. And if it will use the arterial waveform, it will use the diacritic notch as a surrogate for the beginning of the diastole, so it will start the inflation of the intra-aortic balloon. And as you see, there are many trigger source, as we explained the ECG, and we also explained the pressure waveform. And you can use also the based rhythm in order as a trigger to inflate and deflate the intra-aortic balloon. And also you can go to use the internal mode if the patient is having cardiac is on cardiopulmonary bypass or is having a systole, so you can go to the internal mode. And the internal mode basically work by setting like a fixed heart rate between 40 and 120, and the default is around 80 beat per minute. And based on this, the balloon will start the inflation and the deflation. So the internal mode is simulating the ECG, but in those patients on the cardiopulmonary bypass, because they are having cardioplegia during the run out of the cardiopulmonary bypass, and those patients who's having a systole, so you can put them in the internal mode, and the machine will simulate like an ECG and will start the inflation and the deflation uh, of the balloon. But if you are using the based rhythm, you have to make sure that the patient is having pacing 100%. So this patient is having a pacer, and it was used the trigger as pacer AV. But the patient throughout the all not all the times having the paced rhythm. Here you have the paced rhythm, atrial and ventricular paced rhythm. But here the patient lost the pacing of the pacemaker, and also consequently the intra-aortic balloon stopped the augmentation, as you see here. So if you use the pacer rhythm as a trigger for the intra-aortic balloon, you have to make sure that the pacer is delivering 100% pacing. The timing of the intra-aortic balloon. The timing is referred to the point of inflation and the point of the deflation of the intra-aortic balloon. Ideally, the point of inflation of the intra-aortic balloon is at the mid of the T wave, which is just prior to the diacritic notch. And here at this time, at this point, this is the inflation point. The intra-aortic balloon will start the inflation, and it will, once start the inflation, it will reach to the plateau till it reach to the deflation point, which is the peak of the R wave. And after that, the balloon will start the deflation, and you will have the deflation R. The IABP frequency, the operator can set the IABP frequency 1 to 1, 1 to 2, 1 to 3, and in some intra-aortic balloon, the ratio, it can go higher to 1 to 8 in some devices. And this is an example for 1 to 1 ratio, where each cardiac cycle is supported with the intra-aortic balloon, and 1 to 2 ratio, each alternative cardiac cycle is supported with intra-aortic balloon, and 1 to 3, each third cycle is supported with intra-aortic balloon, as you see. The IABP augmentation, when you start the running of the intra-aortic balloon, you should set the augmentation percentage 100%, and the minimum augmentation should be 70%. Augmentation less than 70%, it will increase the risk of the balloon thrombosis. So when your patient starts the stabilization and he became ready to weaning, so one of the weaning methods is to decrease the augmentation percentage of the intra-aortic balloon, and gradually, if your patient, when you reach augmentation of 70%, if your patient is stable, so you can remove the intra-aortic balloon. The intra-aortic balloon augmentation can be affected by many factors, like causes of reduced intra-aortic balloon augmentation. You will find causes related to the patient, and causes related to the balloon, causes related to the catheter, and causes relating to the setting, which is the timing factors. The causes related to the patient, like if he's having tachycardia, and if he's having low stroke volume, is having very low mean arterial blood pressure, and systemic vascular resistance is very low. All these factors will reduce the intra-aortic balloon augmentation. And the balloon factor, like if the augmentation percentage has been reduced, so it will reduce the intra-aortic balloon. And the catheter factor, like if the catheter is leaking, so this will lead to poor balloon inflation and reduced augmentation. And or if the catheter is kinked, so this will lead to poor inflation and poor deflation, and consequently reduced augmentation of the intra-aortic balloon. And if you are not adjusting the time properly, so in case of late inflation, so the timing for the balloon augmentation will be less suboptimal. And if you are having early deflation, so the intra-aortic balloon augmentation, it will be reduced. Going to the balloon pressure waveform, and as you see, this is the normal balloon pressure waveform. So you will have the inflation limb, and you will have the inflation overshooting, and after that, you will have the plateau, and reaching to the deflation point, you will have the deflation arm and deflation overshoot, and you will go to the baseline. The baseline of the balloon pressure should be between 10 to 15 millimeter mercury. And once the balloon inflate, you will have this inflation overshoot. And after that, the pressure when the intra-aortic balloon will start the inflation, so there is a pressure inside the intra-aortic balloon, and also there is a pressure inside the aorta. So when the intra-aortic balloon will inflate very fast, so the pressure inside the intra-aortic balloon will cause this inflation overshooting, and after the balloon totally inflate, so the pressure between the inside the aorta and the pressure inside the balloon, it will reach to the state of equilibrium, and you will reach to the plateau. And after you reach to the deflation point, so you will have the deflation arm and the deflation overshoot, because the intra-aortic balloon also will start the deflation very fast. So the pressure inside the balloon will be more negative, and after some time the pressure inside the balloon and the pressure inside the aorta, it will reach to the state of equilibrium, so you will go back to the baseline. Initiation of the intra-aortic balloon. So you will switch on, and you are expert in this one. So you switch on the machine, verify the helium supply, connect the ECG, connect the arterial pressure source, then zero the arterial line, connect the IABP catheter, select the trigger, augmentation 100%, then start. And after that, you have to put the intra-aortic balloon into 1:2 ratio in order to assess the timing of the intra-aortic balloon, if there is any troubleshooting with the timing, like early late inflation or early late deflation. So you have to adjust the setting for the timing based on the semi-auto mode and uh, the timing of the intra-aortic balloon. Patient assessment during the run out of the intra-aortic balloon. So this is your patient, and this is the intra-aortic balloon, this is the catheter, and this is the console, and you will have this line connected to the arterial transducer, which is connected to the hips line in order to maintain the patency of the arterial line. And during the assessment of the patient, you have intra-aortic balloon, which is sitting here in the descending part of the aorta. So if this balloon migrated upward, so it might occlude the blood supply going to the left subclavian artery. So you need to assess the left radial pulse daily. Usually each shift you have to assess the radial pulse. And also because the intra-aortic balloon is inserted in the femoral artery, so you have to assess the pedal pulse and dorsalis pedis pulsation. So you have to assess the pulse state of the patient, the radial, and the pedal pulse and dorsalis pedis artery. And also you have to assess the urine output, because if the intra-aortic balloon migrated downward, it might occlude the blood supply to the kidney. So you have to monitor the urine output for the patient. So you will assess the radial pulse, the insertion site. You have to assess this in order to assess for any hematoma or bleeding. Sorry. And also you have to assess the pedal pulses, and you have to assess the inner lumen of the intra-aortic balloon. You have to make sure that the bag is filled with saline and inflated properly. And you have to check the urine output, and to check also the catheter tubing. So in case if you found the blood inside the catheter tube, so it might alarm you that the intra-aortic balloon might rupture if you found the blood inside the tube. If you are treating a patient with cardiogenic shock, so you will have targets. You are targeting to increase the circulatory support, meaning that you need to increase improve the hemodynamics for the patient, like the main arterial blood pressure. And also you have to avoid the LV distension, like you need to decrease the left ventricle end diastolic volume and end diastolic pressure. And also during the treatment of the cardiogenic shock, you have to improve the coronary perfusion. So regarding the circulatory support, so you are targeting to increase the main arterial blood pressure, and you can do this by introducing vasopressors or inotropes, or you can use the mechanical circulatory support like the intra-aortic balloon, ECMO, Ambella. And during that, you have to monitor the main arterial blood pressure. And if you are targeting to unload the left ventricle, so you have to decrease the left ventricle pressure and left ventricle volume. And you can do this by introducing diuretics and inotropes. And you can use the help of the intra-aortic balloon or Impella. Both of them will be able to decrease the LV distension and LV venting. And during that, you can monitor the patient by the pulmonary artery catheter using the pulmonary capillary wedge pressure measurement, and also you can use the echo in order to assess the diastolic function of the heart. And regarding the coronary perfusion, you should target to increase the diastolic pressure time index, and you will achieve this by either to do PCI or to optimize the hemodynamics, or you can use the intra-aortic balloon pump, so this will increase the coronary perfusion. And during that, you can monitor the patient by the ECG and the troponin. So if the ECG is regressing and the troponin is declining, that means your coronary perfusion is optimized. Hello? Hello?
Yes.
You can hear?
Yes, I think.
You want to continue the lecture, or we can continue later on? The troubleshooting. We can make it the last part.
Yes, I think that would be I think we can ask. They agree or?
Okay. Any suggestion from others?
Yes, we can continue in next lecture.
Okay. Any question from your side?
Yes, one question from my side is,
Okay.
normally we consider that AT pressures are usually good for the diastolic diastolic filling of the
Augmentation.
coronary arteries.
You mean the diastolic augmentation, the diastolic pressure,
No,
the augmented pressure?
normally we consider AT pressures in the diastole are the good for the filling of the coronary arteries. So it is
what is 80? 80 what?
80 millimeter of mercury. Like diastolic pressure is 80 normally, and systolic pressure is 120. So we consider that 80 pressures are enough to perfuse the coronary arteries.
You mean the augmented pressure?
No, I'm just talking about the normal phenomena. Now coming
the diastolic. You mean the diastolic pressure or the augmented pressure?
No, I'm just talking about the diastolic pressure in normal phenomena.
Because normally you are targeting diastolic more than 40 diastolic pressure. If the diastolic pressure more than 40, it will be enough to perfuse the coronary blood flow.
Yeah, maximum means 80, 90. And
yeah,
we consider that if there is a high diastolic pressure, we might have a chance of myocardial infarction because our coronaries are not filled under more than 90 or 100 pressures.
Okay.
But in case of IABP, the augmentation pressure is actually the diastolic pressure. That is maximum.
Yeah. I agree with you.
Maximum.
Okay. Yes,
like
I agree with you.
Even more than the systolic pressure.
But in this patient with heart failure, you are targeting systolic 120?
Whenever we introduce the IABP, we insert the IABP, our augmented pressures are mostly more than systolic pressures, like 100, 110, 120, or 130 sometimes. So
because this patient, I know, you know that this patient is having weak heart. So if you increase the systolic pressure, you will increase the afterload for the heart. So the heart will not be able to increase the stroke volume. So it's better to maintain the systolic blood pressure between 90 to 100. But more than this, you should introduce other agent in order to decrease the afterload. So you should come down with the systolic blood pressure. This will help the heart to eject more blood and increase the stroke volume and cardiac output.
yes, but even when we are talking about the systolic pressure 100 or 110, at that time our augmentation pressures are even more than that, 10 or 20 millimeter of mercury more than of systolic pressure. Then how we justify
Yeah,
the
this is if you are using the intra-aortic balloon, you should increase the augmented pressure, and usually the augmented pressure
my question
ideally,
is
uh-huh.
my question is normally we consider 80-90 diastolic pressure is good for the coronary perfusion, but in case of IABP we consider more than 100, 110, 120
110, yes.
for the perfusion of coronary arteries. What is the justification
Yes.
behind this?
Because it will increase the coronary blood flow.
Yeah, but in normal scenario, we say that if our diastolic pressure is more than 90 or more than 100, it's not good for coronaries. We might have a MI. But in IABP case, we consider more than 100 and 110, 120. What is the phenomenon?
I'm not getting the question. I don't get it.
Yeah,
I think your question about the diastolic inflation, the diastolic inflation, you mean?
The question is about coronary perfusion. In normal
Okay,
person without having IABP like us, we consider 80 to 90 diastolic pressure is good for the coronary perfusion.
In normal person without MI, you mean? Without MI?
Normal man, in normal human.
No, in normal human, you need diastolic above 40 to maintain the coronary perfusion.
Maximum. I am talking about maximum limit.
Yeah, maximum. Yeah, okay.
Limit is 80 to 90. But
80, yes.
But when we talk about the IABP, so in IABP, the diastolic pressures, that is called the augmented pressures.
Okay. Yes.
These are even more than the systolic pressures when we talk about augmented pressure. They are more than even systolic, and they are for the coronary filling.
Yes, this is this is the whole idea about the intra-aortic balloon. Let me just I will show you one slide. I want to show you one slide, okay? You are talking about this one? You can see this slide?
No, we can't see.
Actually, the function of the IABP is that to increase the augmented diastolic pressure. When IABP is able to generate increase the augmented diastolic pressure, that is the time when coronaries are perfused maximum.
So you can see this slide now?
This is the carry under the curve,
Yes.
Which is called the diastolic pressure time index.
You can see this slide now?
Yeah, we can see.
Okay. So the first part of the slide, this is the unassisted waveform, and this is the diastolic pressure. Okay. So this is the diacritic notch. This is the peak systolic pressure, and this is the diacritic notch, and this area is the area of diastole, the area under the diastolic curve. Okay. So the idea of the intra-aortic balloon is to increase this area under curve, because this area under curve is a surrogate for the coronary perfusion. So if you increase it like this one, it will increase the coronary blood flow.
Yeah, it's increasing the coronary blood flow.
And this is the idea of the intra-aortic balloon, to increase the coronary perfusion, because this time for the diastole is the time for coronary filling for the left ventricle mainly. Okay, left coronary artery.
Yes.
It's filling during the diastole. So if your patient is having MI, so you should increase, you should make the patient a little bit not tachycardic. So you will increase the time for the diastole. So it will increase the time for the coronary filling during the diastole. And the intra-aortic balloon will increase the area under curve, but will start because it will start the augmentation during the diastole. Okay, so if we are targeting diastole in normal patient maximum of 80, so if you are using intra-aortic balloon, the diastolic pressure should be 110, 120, right?
Yes, yes. I am talking about 110, 120 pressure.
Yeah, this is the one. It should be higher than the systolic pressure. So the systolic
Yeah.
should be 100. So the systolic should be 100 and the augmented one should be 120.
Yeah. I'm just
Right?
talking about this thing that in normal person we consider 80 pressure is enough, 80 to 90 pressure, not more than 80 to
Yes.
90 pressure. But in
Yes, yes.
IABP case, we are considering more than 120 and
Yeah, you are right. You are right.
This is my point.
Yeah, okay.
Actually, if I can say something on this one,
Okay.
what I'm getting from Bakar is that this diastolic pressure in normal circumstances is when the heart is contracting without a machine. So that
Yeah.
increases, then the workload for the heart will increase. If the diastolic pressure in normal, in high blood pressure, for example, it crosses 100, then that will increase that will not decrease the afterload. That will increase the afterload for the heart, and that will be a lot of struggle for the heart, and that may cause MI. But here, with this machine, if you increase the diastolic pressure, then it does not leave it like that for the heart. When it's contracting, suddenly the IABP goes in deflation, and at that time, this pressure comes down,
Yes,
which the heart is actually facing. So that decreases the afterload for the heart, and that
Yeah.
helps
Decrease
both
the
the
oxygen
coronary
demand.
and systolic, pressure of the heart, and so work afterload also goes down. That's when
So
it
yeah.
friendly with the
So the
heart.
intra-aortic balloon increase the oxygen supply by two ways. Okay, it will increase the coronary perfusion because it will increase the this area under curve. This area under curve, it will be maximized by the intra-aortic balloon, so it will increase the coronary perfusion during the diastole. And the other thing is that during the systole, it will decrease, as you said, decrease the afterload. So if you are treating a patient with heart failure, you have to match the balance between the oxygen demand and the oxygen supply. You can increase the oxygen supply by the intra-aortic balloon, and also you can decrease the oxygen demand by reduction of the afterload and systolic blood pressure.
If this curve,
So the intra-aortic balloon, it helps the heart during the systole and the diastole.
Exactly right. So if this curve is on its peak left like that, it will, in the same way, it will be dangerous for the heart. But when the balloon deflates, this curve comes down. So at that point, the heart steps, so that decreases the afterload for the heart.
Yes, you're right. Correct.
There is one slide. You want to say something?
Sorry?
Hello. You want to say something?
No.
Yeah, I want to say something.
Okay.
My actually want to know about, there is a assisted and unassisted systolic pressure.
Okay.
Unassisted is usually higher than assisted. So
One
what
second.
is the
You mean this one?
Yeah.
Okay.
Unassisted is usually higher than the assisted pressure.
Yes.
So why assisted pressure, systolic pressures are lower than unassisted?
So this is the deflation point of the intra-aortic balloon, right? Here, the intra-aortic balloon will start deflation, and the deflation of the intra-aortic balloon, it will be very fast. Okay, right?
Yes.
And so you will notice that there is a drop inside the aorta.
Yes.
Marked drop inside the aorta, and this will come down, will decrease the diastolic pressure, and the assisted diastolic pressure, it will go down, and also the systolic pressure also inside the aorta, it will go down.
Yes.
This is what is called a vacuum effect of the intra-aortic balloon. Vacuum effect, that means the balloon was inflated and causing a pressure inside the intra-aortic balloon, right? Inside the aorta. So when the balloon rapidly deflate, it will deflate very fast. So it will make a vacuum or negative pressure inside the aorta. So all the pressures inside the aorta, it will come down. So you will notice that the assisted systolic pressure, it will be lower than the unassisted systolic pressure. And also the assisted end-diastolic pressure, it will also go down. All the pressures will go down. And this will decrease the afterload during the systole, right?
Yes, Doctor. And this is the same waveform that we are used during adjusting the timing of the IABP inflation and deflation.
Yes.
When we
Yes.
adjust in a 1:2 ratio and set the reference line according to
Yes.
this waveform and inflate or deflate according to this.
Yeah, and if the timing for the deflation was prolonged, that
Yes.
means the patient is having late deflation.
Late
So
deflation, yes.
instead of it's coming here at this point, so it will come at this point. So you will notice that the assisted end-diastolic pressure, it will come higher at higher level, and also the assisted systolic pressure, it will be higher. It will be almost equal to the unassisted one. Okay.
Yes, if it is if both are equal to each other, then there is no benefit of IABP.
Yeah. Yes,
Yes.
because the afterload is increased, and it will increase oxygen demand and the workload by heart. So the timing is very important. That's why if you are discussing the intra-aortic balloon, you should know the cardiac cycle and the timing and which valve is opening during the systole, which valve is opening during the diastole. The aortic valve will open when, it will close when. Mitral valve, it will open at which time, right? So the physiology behind the intra-aortic balloon is very essential. You have to know the timing, which of the cardiac cycle, which is very essential.
That's good. Actually, it's not exactly a question. It's just there's a query. When we are selecting the balloon catheter sizes, we have two sizes which are kind of similar to each other. One is this 7FR 40cc, and the other one is 8FR 50cc.
This one you mean?
Yeah, there is a 7FR 40cc available, and there is an 8FR 50cc. So these are kind of similar to each other. If I don't know if we have an idea about this one, because if the FR decreases and the volume stays the same, then the catheter length increases. I don't know if you are getting.
Yes.
So it becomes, if it's 7FR with 40cc, will have the same length as 8FR with 50. So what things play in your mind while selecting the catheter? Is it an obese patient, or caliber of the vessel, or only the tall patient, same heighted patients? What do you consider the factors for selecting the size?
No, I think you are expert in this issue more than me. What I know that you are using the size based on the height.
Yes, it's only related to your height, yes. And 40cc means it's a helium gas inside the balloon, and the size like a 7FR. 7FR means the caliber diameter of the balloon inside the aorta, and the 40cc is the filling pressure inside the helium balloon. And yes, 50 and the size it's matters according to the height of the patient, not related to like obese patient or like this.
So if you have available an 8FR 50cc catheter and also a 7FR 40cc catheter, so what would you prefer in this?
Again, if you have what?
If you have a 7FR 40cc balloon catheter, we have 7.5FR 40cc, we have 7FR 40cc, and we have 8FR 40cc as well. So
Which one
would
will achieve the highest occlusivity?
both will achieve the same exclusivity.
But one will be longer, the other one will be like shorter.
8 FR 50 cc and 7 FR 40 cc are almost the same.
So I will prefer the longer one, I think. If
Both have
both
the
of
same.
them,
It also
if
depends upon the height of the patient.
yeah,
Both can do the same job for
Definitely, there are other parameters also, not only the height. We consider the height, then definitely we will go for the patient weight and how much he is obese. So definitely other parameters we can consider.
who is as heighted as the other person with smaller, an obese patient. If I take two patients, an obese patient with same tall patient and a less weight, like a normal person with the same height. Obese patient may have slightly lesser diameter or the excess of the vessel as compared to the other person with the same height. So I think this caliber of the vessel and also your approach, if 8FR is possible for you or not, should also matter along with the height of the patient.
What about if the patient is having a small femoral artery?
Yes, exactly. So 7FR 40cc would be a better choice as compared to this 8FR.
Yes. So there are many factors
Yeah,
will affect your decision.
Actually, we are not considering the insertion of the 7FR or 8FR. It is, I think, it's easy to insert because artery is a bigger size, not.
But this patient,
Actually, what
this
we
patient.
consider. No. Actually, what we consider is the body volume. If the patient is more bulky or fatty, it has less volume. But if it's muscular, it has more volume. So we can consider accordingly.
Yeah, for obese patients, why do we use like 5FR Unisig for an obese patient? The reasons and
For what?
for obese patients, we are using Unisig. It's also a point, I mean, to consider. Why not any other like 6FR introduce a sheet that we are using? I think Dr. Musli would give us.
Yeah, definitely approach is difficult.
Difficult approach. Yeah, exactly. So for that, I think 7FR 40cc would be a better choice as compared to an 8FR 50cc for that patient.
But actually, when we're discussing about the balloon, we are discussing about the blood displacement. So we must consider the blood displacement instead of inserting approach.
Explore this thing. My suggestion was only on these two capsules. I mean, they offer the same kind of occlusivity and the length of the capsule. That's what my information.
Trade for me to read about this topic. There is a lot of conflict.
Yeah.
Okay, but you guys expert in this. You know that we are relying on you to to select the size of the intra-aortic balloon. I learned this from all of you.
Yeah.
And I have even, I think last time, that patient was in S4. I don't know who of you attended this case, but they brought the patient from the cath lab. His weight was around, his height was around 180, and they put for him 30 cc catheter, unfortunately. And the patient was vitally unstable, and there was alarm that the intra-aortic balloon was going to standby mode because there is alarm of catheter. I don't remember the alarm. So we changed the intra-aortic balloon, and we put the 40 cc catheter, and the patient after that he became more stable, and actually the augmentation was much better.
Definitely.
So really the size of the intra-aortic balloon really affect the performance of the intra-aortic balloon.
Should be appropriate, must be.
Yeah. I just want to remember the alarm. I took a screenshot for this one.
This is important.
Anyway, we are really looking forward to troubleshooting session.